So did they?
Test 1, 2, we're going.
Awesome. Okay, so who's on the phone just so we can pretend you're here with us live?
This is Rebecca.
Hi, Rebecca. I hope you're feeling better.
And this is Dana.
Awesome. Hi, Dana. Thanks for joining us.
And my family from Portland.
Woohoo! And Dr. Reck. We are so cool tonight. All right, we got the whole posse. So we're just going to go ahead and mute you guys, but if you have a question, I think you can just text, email it in, or whatever what the normal thing is. Luke's in charge. And like Luke said, we're going to go ahead and record this so that different community members can listen to it, just because I imagine this is a hot topic for a lot of families and community members. So kind of how this panel came about, and I'm going to kind of set some ground rules and then introduce the two folks with me, is that, the day after the election, I started getting phone calls from Nicolette and Heidi being like, what does this mean? I'm like, not good. But let me figure it out. And then Nicolette kind of challenged me, what can you do now for the community? And I like a good challenge. So I figured that the best bet to do is try to get some professionals with me in the room who could kind of help to describe what's going on at the federal level and what's going on at the state level. And what the BDFW can do in the next few months as this unfolds, and year as it unfolds. And the point is to have a factual conversation versus a political conversation about, who won and why, and who voted who and where, and all that kind of stuff, because it just today is what it is. And I think that's really exciting about the three of us here is I'll kind of help moderate and help clarify, because sometimes when political nerds get in the room, they start talking about Dems, and I was talking to someone, it was Eric the other night, and pretty political, and he's like, what's a Dem? I'm like, oh, Democrat? I'm like, so help translate. Maybe you just didn't want to pay attention to me. And so it's like sometimes things need to be translated. For questions, our thought is that we have index cards. People can kind of put them down. And then for clarification questions, definitely kind of, put your hands up and we can kind of get it specific, but really respecting everyone's kind of views and really kind of sticking to what's going to happen. And so I'm going to introduce Kim Eisenberg, and she now works for Shire, formerly known as Baxalta or Baxter. And she is the head of government affairs.
U.S. Patient Advocacy.
U.S. Patient Advocacy. So, and Kim is fantastic. And I've worked with her now for a number of years. And I was always willing to provide that political insight, especially on a lot of our advocacy efforts, just because she's been doing this for a really long time. And then Erin Jijic is our BDFW lobbyist in Olympia, and has been now this will be her third year as a full-time lobbyist. Before she monitored for us for a year, and so she's become very fluent in all things bleeding disorders.
As much as I can get there, you guys have seen me down there. I can say enough now and then bring you in for the close. That's
yes.
That, yeah.
But Erin's great because she really focuses on patient advocacy specifically, so she doesn't carry any conflicts of interest, which is important, I think, for hemophilia. And then for me, so obviously I work for BDFW, but then I've worked down at the state capitol before and worked for different elected officials. And I was talking with Kim, we got a chance to meet beforehand, is that I think that's really valuable about the three people here is that they have all worked for elected officials. And there's some of our government affairs folks that work for the different drug companies have never actually worked for an elected official or have never worked in government. And it's very different when we talk about some of these things on, is it or isn't it going to happen? Is this what this is going to look like? Is it a lot of this, what's going to happen is because it can, it will. There's more loyalty to party than there is to policy, than there is to patient advocacy groups. And so I think that everyone kind of brings a really great perspective on what it's like to live the day-to-day of watching legislation being passed. Or not done, or undone. Mm-hmm. But just, I think it's great that you have the three of them here to kind of tell you what their experience is, and I think that everyone's been following this closely, and I know that both of them are on a lot of calls with a lot of other big entities. So I thought we would go through this. So Kim's going to kind of focus on the federal Erin will do the state, and then we'll kind of talk about the BDFW and what it can do over these next upcoming months.
All right. You want me just to jump in?
Yeah!
All right. Okay, well, I'm going to start with so hi everyone. Thanks so much for asking me to join you tonight. I was telling Stephanie this morning, like today was one of my best work days ever because I sat in front of the computer and just did research in preparation for this afternoon. And I do consider myself to be pretty policy nerdy. I have been doing work in the field of politics since 1981, so that's a really long time. And sometimes I forget, why does that stuff just come off my tongue like I know what I'm talking about? Oh, I did an internship at the Minnesota legislature in 1981, and I've been doing this ever since. And I know there's a lot of people in this room that weren't even born yet. I know that's how it works. So I'm going to talk a little bit about just sort of what happened with the passage of the Affordable Care Act and what are some of the things in the Affordable Care Act that have been beneficial to the bleeding disorders community. And then we're going to talk a little bit about what can happen now. We don't know exactly what will happen yet. That's a lot of speculation. And then some scenarios. So one of my jobs in my career was that I worked for Governor Jesse Ventura. And after working for him, I did crisis communications for 2 years because once you've worked for Jesse, you learn crisis communications. And so it's really important to think about those scenarios. What's the best case scenario and what's the worst case scenario? And how do we, as we go through tonight, talk about how do we prepare for both ends of that spectrum. So a little bit about the Affordable Care Act. You guys know most of this, but it'll just be a good level set for our discussion tonight. There were a number of, I think I'm on the wrong page. I want to make sure I cover the things that I thought were really important to cover. So the Affordable Care Act has impacted both private insurance, so insurance through your employer or the individual marketplace, and public insurance, so Medicaid and Medicare. And I'm just going to hit a handful of really high-level parts of the bill because it was a really, really big bill with a lot of complications, some of which we still haven't even seen. Some of the things that were passed won't even be implemented or start until 2017, 2019, and so who knows what will happen to those. But anyway, some of the key provisions are, first of all, we all know that we can keep our children on our insurance plans until they're 26 years old. Only our children, even if they're married or have children, their spouse or their children can't be on our plan, but they can remain on our plan. We know one thing we rarely hear anyone talking about anymore is one thing the Affordable Care Act did was that it banned an insurance plan from rescinding your coverage once you got sick. So you guys may remember in this community there were people who had insurance and then were diagnosed with something or had a child that had hemophilia and lost their insurance. It was rescinded simply because they had someone in their family that was sick. We don't talk about that provision in the Affordable Care Act very much anymore at all. And then, of course, the banning of annual and lifetime caps. We don't hear a lot of talk about that right now after the election or during the election. Very, very little talk about what will happen to lifetime caps and annual caps. And of course, the banning of pre-existing conditions so that an insurance plan could deny you coverage because of a pre-existing condition. That is another thing that the Affordable Care Act provided to all citizens of the U.S. And finally, it gave states the ability to expand Medicaid to 138% of poverty. When it first passed, as you may recall, it was supposed to be for all states. But the one thing that the Supreme Court turned down in the fight to keep the Affordable Care Act was that the Supreme Court declared that a state does not have to expand Medicaid. It did uphold the individual mandate, but it did not uphold that states expanding Medicaid. There are now 32 states that have expanded Medicaid.
I think, also for expanded Medicaid, and then we can add in that one, is that it also made it so that a single individual could get insurance. So for us, that was really huge, so that a young man who's 22 or even somebody who's 45 could get insurance, and that was a really, really big deal for our folks.
Because as you may recall that Medicaid was originally created for women and children, and it meant pregnant women and her family for coverage. And typically when a young man particularly reached the age of 18 and was considered an adult, and it was no longer on their mother's Medicaid plan, and it left a lot of folks from the bleeding disorders community without coverage for a certain period of their lives. So
I wanted to add one that we talk about a lot lately in our state is the out-of-pocket caps. She talked about the out-of-pocket maxes being banned, like the carrier can't say, we'll only cover you for this much a year or this much annually, but we also instituted out-of-pocket caps for patients. We've talked about how those are burdensome, but they still are better than what we were facing before. So right now it indexes up, so it's like $6,200 or something per person, around $13,000 I think next year for a family. Before that, we were out of pocket as long as the percentages kept going, right? If you were taking a drug and it was 30%, you would just keep paying. You never hit an out of pocket. And so that's a piece I particularly love. Yeah, it's that I'm worried about.
Important part of it. And it provided for the health insurance marketplace, so the individual marketplace. So for folks who didn't get insurance through their employer, who for whatever reason were denied because they had a pre-existing condition but now could go to the individual marketplace and buy a plan, and a number of other scenarios of why people would go to the individual marketplace to buy health insurance plans. It's funny, when the Affordable Care Act was passed, I worked for Minnesota's current governor at the Department of Employment and Economic Development, and one of the big things that all of the consultants on entrepreneurship talked about is how the Affordable Care Act would finally allow people to go off and follow their dreams because they could buy health insurance on the marketplace.
That's literally when I went out on my own.
So
yeah, because before, how could you buy it? You had
couldn't.
no place to buy insurance.
Right, and it's the whole theme of Ivy leaders. You know, is just go and be a rock star.
Yeah,
because you
to
can
live your dream.
afford
Exactly.
your
As
insurance.
long as you have insurance.
Exactly.
Be a rock star as long as you get insurance.
It's not worth the risk if you don't. Right.
And then in those exchanges, the plans all had what are called the 10 essential health benefits. This is really important because there are things that you would need in the bleeding disorders communities, like to make sure that your lab work is covered. That is under the essential health benefits. To make sure that prescription drugs are covered, those are under the essential health benefits. Before the Affordable Care Act, there are plans that didn't have that kind of coverage, and so this helps to ensure that in those marketplace plans, those essential health benefits are covered. On the public payer side, and also on Medicare, the Affordable Care Act did very little to impact Medicare, but one thing it does do is that it shrinks the donut hole. You may be aware of that there's prescription drug coverage, that there is this part of the coverage that your insurance plan helps you pay for it. Then you get stuck in this donut hole where all of the out-of-pocket costs are borne by the person living or taking that prescription drug until it meets a certain cap, and then the insurance plan kicks back in. Well, the Affordable Care Act is shrinking that so that it would go away. I can't remember right off the top of my head the year it would go away, but in the 2020 area that it would finally shrink to, or 2025. So oh yeah, because I base it basically upon when I'll turn 65, so I'd know that it'd be gone by then. So, which may be similar ages to those. Okay, I wasn't going to get political, was I? There's a little. Sometimes, spending my life in politics, I have to say every once in a while I get a little cynical, but for the most part, I still have great respect for this system that we have. The Affordable Care Act did also provide for a law to appeal denials. So if your insurance plan denies your drug benefit or denies some service that you're getting, there has now been put in law because of the Affordable Care Act a process for appealing and a time frame for appealing. And then I think that just note that under the Affordable Care Act, because of these additional rights for people and the expansion of Medicaid, there are about 20 to 25 million more people who now have health insurance coverage than did before the passage of the Affordable Care Act, and about 10 million of them are on those state expanded Medicaids. And then I will now go to so that's, again, those are just sort of the basics. I think we'll we can kind of dig apart some of that as we're going through the rest of the agenda. And what does the landscape look for any bill that gets passed into law? So this applies to the Affordable Care Act as well as any other bill. If Congress and the President decide that they want to undo some legislation, there are processes in place for them to do that. And in Congress, with the President, there are basically 4 different ways. Some take congressional action, some can take just presidential action. So, of course, the first one that we've heard a lot about in the election was repealing the Affordable Care Act. And while someone can pledge to repeal it, repealing a law is not an easy thing to do in Congress because the United States Senate has what's called the filibuster. And so the body needs 60 votes for what's called cloture so that they can bring that bill to a vote for passage or failure. And after the election, which is still not fully decided what the Senate is going to look like because Louisiana has a runoff race. Right now the number is 51 to 48, 51R, 48D. And so we don't have the 60 votes for cloture. And so to pass the bill, to repeal the bill would be very difficult. There are a number of Democrats who were in who are going to have tough fights ahead. And so there may be some of those Dems who are, who will be willing to negotiate and support the repeal. We don't know the answer to that yet. Again, these are the scenarios that we just don't know. So if repeal is it would take either a long time or is highly unlikely, at least the way we look at it now, what's another option? Well, that's reconciliation. And so in 1974, in order to deal with a deficit back then, there was a Congressional Balanced Budget Act which provided for reconciliation. So you can't repeal the bill, but what you can do is that you can, through reconciliation and the budget resolutions, take parts of legislation that directly impact the federal budget and change those. And you don't need the 60 votes. You only need 51. So that's where there's been a lot of efforts already taken on the Affordable Care Act. It's actually how it got passed in 2010, there was a reconciliation vote that helped provide for bringing the Affordable Care Act to law. And then in 2016, so just this year, Congress passed reconciliation to repeal the bill with a 2-year basically waiting period with what would then be put in place to reform the legislation or replace the legislation. So that's the second way that Congress and the President can change the vote. And the reason 2016 reconciliation didn't happen, even though Congress passed the bill overwhelmingly, is that the President vetoed it.
Can I draw an example there? Because I've been studying this to learn it. Because we have something similar to the state, but not the same. The 3 things that are talked about that can be done via reconciliation that are critical are pull the money for the subsidies, pull the money for Medicaid expansion, and pull the mandate tax penalty, because those all involve money.
Right.
Then you leave on the books everything else,
all the
regulation.
Right.
So the things she just ran through, all the reinsurance and like risk spreading measures, like a lot of the policy stays on the book, but it's essentially defunded, which is a very odd dynamic. In some ways, a full repeal is simpler because it takes everything off the books and we fall back to the marketplace before. Just pulling some money and leaving the policies is really tricky in the individual market, is what a lot of people are looking at. But they may have to do that because of the vote rule. They don't have 60 votes.
They don't have the 60 votes. So that's the second option. Another option is executive order, which means the President, with the stroke of a pen, can change some of the regulation. Now, a couple of examples in that are the essential health benefits that I mentioned earlier, is that those are all in regulation, and through executive order, a president could remove those essential health benefits. I haven't heard any discussions about that happening, but that's an example. But where I have heard discussions is, so one of the things that we briefly mentioned, I guess I didn't really go into detail, is in the Affordable Care Act on the individual marketplace, if you go to the marketplace to buy your individual plan, it's based upon your income, you may get tax credits and cost subsidies. And so the tax credits, the Congress has appropriated funding for those tax credits, but they never appropriated funding for the cost subsidies. So the president was paying those cost subsidies through executive order. A lawsuit was filed by Congress, and it's right now in appeal, and I just read an article before coming in here that actually Congress is now asking the courts to hold off on it because of what they are planning to do with repeal or reconciliation. But if insurance plans feel that they're going to lose, because those cost subsidies go directly to the insurance plan to help pay off the premium and those co-insurance costs. If the insurance plans feel that those cost subsidies are going away, again, they will start moving away from the individual market because they won't be able to make the profit that they're looking for by coming to provide those plans on the individual marketplace. So that's what an executive order can do, and the president can do without any act of Congress that he can on his own do. And finally, and there has been discussion about it, they can amend current law. So rather than taking away or gutting or changing or any of those things, they could look at provisions of the law and amend it. Anytime you try to amend a bill, it's Molly bar the door, though, because once you open it up, anything that's germane to the bill can be brought up. And so typically something as controversial as changing the Affordable Care Act would be one I think that they would hesitate amending. But, you know, a lot of things that I never expected to see I have seen. So who's to say?
Like we would have never, just as an example, if that was state legislation, I would never put forward for that to be opened. It's too big.
Right.
Like there was a bill being looked at being drafted before the election that was so big and important, but it had all these sections of insurance law that we care about, and I'm like, you can't put that out there. There aren't enough of us to work when the amendments start piling in. So that's what she's referencing, like anyone could drop an amendment. We could have some fun. I mean, right? If you're on the other side of it, you suddenly start drafting a lot of creative amendments to slow it down. So it is the better way. You always want to actually like repeal and replace is the way a law is typically amended. That's what amendment is. But I don't know how you open up. How many pages was that finally?
It was like 3,000 pages. And
It's huge.
when I worked in the legislature, again, we called it a Christmas tree
Yeah,
bill.
totally Christmas tree.
So that, you know, it's like every year you get a new ornament, and you just keep adding ornaments and lights, and before you know it. So I mean, again, it could be they could move forward with amendments, but the chances of that seem it's hard to imagine, but it certainly could happen. And I think it's sort of how do the different scenarios impact the bleeding disorders community. I think we talked a little bit through that, and I think as we go through the evening, I think we'll be able to lay that out. But I think that the biggest concern right now, as you read from the different analysts who are looking at what could happen, is that insurance plans come up with you know, their premiums, you know, how they're going to cover people, what the reinsurance looks like, how minimizing risk, all of those things. It takes them a long time to, you know, to come up with what each of those plans is going to look like and analyzing the communities that they serve. And they need to go to the states that they're offering plans early in 2018 or in 2017 to show them what their 2018 plans are going to look like. And if they don't know what's 2018 is going to look like in the first quarter of 2017, they're not going to bring plans to market. So
our plans are due in April. Their initial turn into our OICs in April.
Is April. So right
OIC
the beginning of the second quarter.
Sorry.
See, there you go. and so you can start seeing right away, you know, the unraveling of the Affordable Care Act based upon not having that predictability, based upon the uncertainty that insurance plans really need to do everything they can to build in those certainties and predictabilities so that they can help ensure for those that are for-profit organizations, you know, to give, you know, so they have something for their shareholders, for those that are nonprofit, for the other reasons that are part of their mission. And so they're looking at how do they make sure that they, you know, that they're able to make money and provide the care that they say that they're going to provide. And finally, I just want to, you know, I took a look at what was in the President-elect's campaign plan for health for the Affordable Care Act or for any health policy. He had changing the tax code to allow individuals to fully deduct all health insurance premiums, allowing insurance to be sold across state lines, which insurance plans really oppose, really strongly oppose. Price transparency for medical procedures and other healthcare costs, expanding access to health savings accounts and making them tax-free. Medicaid block grants to states. I think we should take some time to talk a little bit about that yet tonight, because that's a big thing, and so Erin will be able to talk about that. And importation of drugs, so importing drugs from Canada and other countries. So that was, sort of the basis of his plan, and I just, thinking through what we just talked about, some of those might impact the Affordable Care Act, some of them might not, but there you go.
Well, and two things that you and I chatted about earlier that I think would be great is one, talking about how long it actually, because we hear about repeal and replace. How long did it take originally to write the healthcare bill as it is? Because I find it really fascinating. It was actually being written years and years and years before the current president was elected. So that's why they were able to do it so quickly. If you can talk about that, and then CHIP as well.
Oh yeah, I didn't mention CHIP, so it's really important to mention CHIP. So let me go to CHIP first. So the Children's Health Insurance Plan was passed before the Affordable Care Act, and to date has probably covered about 8 million children. It basically expands Medicaid to children at the state level. And
specifically hemophilia too.
And it's been really good for the bleeding disorders community to help cover children with bleeding disorders. So when the Affordable Care Act, and everybody sees it as phenomenal legislation, has done wonders for the health of kids in the United States. I've not heard a negative from any side of the aisle ever about CHIP. But when the Affordable Care Act was passed, the vision was that CHIP would eventually go away because there would be universal coverage, and all of what CHIP has done for children would be provided for through the Affordable Care Act. Now, I'm not exactly sure why there was the concern, glad there was, but there was concern about what would happen to CHIP as we were implementing through phases the Affordable Care Act. And so Congress passed legislation to keep CHIP in place until 2019. Again, if that's all part of the Affordable Care Act, so if it's repealed or through some of the reconciliation language, losing the extra $23 million that has gone, or $23 billion that has gone to CHIP because of the Affordable Care Act, these have a huge impact at the state level and how states can serve children health care needs. And if there is repeal or reconciliation, it could mean also that CHIP would go away. So something to be aware of as you're thinking through what are some of the things that have really helped the families in the state of Washington make sure that they're able to get the health care coverage that
So
they
CHIP,
need.
though, is so bipartisan supported that could have a replace bill move on its own.
It could.
And have the votes. Like, a lot of us have worked CHIP reauthorization prior to ACA, which had like a tobacco tax that funded it.
Right.
And stuff. Like, it really, in our delegation, it's supported by most. Like, I feel like, tell me if I'm wrong because I don't work federal, CHIP is caught in some crosshairs because it was merged with ACA.
Right.
But I have hope that, like, congressional members would work on, if CHIP got jeopardized, how to pull it out and reauthorize. Like, it's going to be tricky, and a lot of what I say is we're going to have to allocate time on stuff we never thought we'd have to keep working on. But that piece, tell me if I'm wrong, I remain really hopeful that CHIP in some form would continue. It just may take an act to reauthorize, and that makes me nervous because then there's a bill moving about CHIP that could change it or do something.
And I think that's it, Erin. I think that the issue is making sure we're aware of this possibility so that it is part of our messaging, it is part of our voices. We need to make sure to protect CHIP. If anything else, let's preserve this. We know it works. It's worked, since its passage in 2000.
You say you'll like this. Remember this? You like this.
You like this.
I
like
wanted to get lost, and I wanted to be called out on its own a little bit too. Of like, don't get swept up. Don't let CHIP get swept up in this too much.
Yeah.
Maybe that's pipe dream. But.
Well, and CHIP is really important too, because so every year at camp we go through and we see what kid has what insurance, and depending on the year, it's either 40 to 60% of our kids are on Medicaid. that are at camp. Most of those are funded through CHIP.
Yeah, it's been a really important legislation and law that has really made a big difference. And I think that knowing any of these changes are not going to be easy. While it sounds, there are these campaign promises that say, we're gonna, day one, these are all going to take time, which is what we're going to talk about, the opportunities we have to have an impact and have a voice in this process. And with regard to, drafting of legislation and therefore, pulling it apart or getting rid of it, these things do take a lot of time. And I've read a couple articles that basically say that the Affordable Care Act was really starting to be written back in the early 90s. And then it's based upon all the experience they had, whether it was through the efforts that Clinton had to pass health care reform, or whether it was taken to the state level, like in a state like Massachusetts where they passed universal coverage, and how those models helped create the Affordable Care Act. There are parts of the Affordable Care Act, like the lifetime caps, that you guys know very well because the bleeding disorders community was leaders in getting rid of lifetime caps. That bill never became law on its own, and it didn't get to the president's desk on its own, but it was easily put into the Affordable Care Act because of all of the work that was done ahead of time on drafting what that language would look like and how important it was to making sure to provide coverage for people, particularly people with rare diseases or high expensive cost medicines. So that's a little bit of the history.
Well, is there currently a replacement plan?
Oh, there is no replacement plan. So again, ever since the Affordable Care Act passed, the following congressional session, bills were introduced to repeal it. There was never anything introduced to replace it. There were always discussions that it was going to be repeal and replace. They got to the repeal part, but there's nothing that's been ever written or drafted about replace. There's a lot of discussions, there's a lot of different ideas that people have, but nothing has been firmly put forward to have a public discussion on what's good about it, what's bad about it, what can we amend, what can we fix. So when they passed the reconciliation reconciliation language in 2016 that got vetoed by the president, what they put in that bill was, as I mentioned before, that we will repeal the Affordable Care Act, but we won't implement the repealing of it for 2 years, so there's 2 years to start moving towards the replacement. As you guys know, how long did we just say it took to put the Affordable Care Act together? It took a long, long time, probably a decade, if not more. And so is 2 years enough to replace if they repeal is the question.
Yeah, and I would say a little like inside baseball kind of politics on that is like they knew it would be vetoed, right? So you can put it forth and say we're going to replace it knowing it's going to be vetoed. So it's okay that you don't have a plan in a sense.
Yeah.
And that's, it's a strategic move so you can go out to your constituents and say, I voted for the repeal.
Right.
Or, or the reconciliation or whatever it is. And so some of that is what I think we're kind of seeing play out too.
Yeah, they're stuck.
Yeah.
They don't have ideas. Health savings accounts and cross-state sales are so tired as ideas that have been vetted and tried, right? Health savings account are great. I mean, they serve a need. It's for like rich people that want flexible dollars and can use a tax benefit. That actually helps a chunk of people, but the thought that like Medicaid would transition to health savings accounts is a joke. But they're a useful piece. Like they could be added into the landscape. Cross-state sales we've looked at so many times in our state, and the bottom line is like for people on the exchange that are getting a subsidy, they're not going to be able to afford plans sold out of any other state either, and there becomes a real network problem, as you can imagine. Like we really don't want someone here purchasing a plan from like Wyoming, because I would be really concerned about what doctors are in the network, and it has functional problems. My insurance used to be out of Georgia when I worked for the Cancer Society, because that was our hub office, and like there's laws on our books that actually make certain benefits not be able to be used here with certain providers that I bumped up against. So it's funny because this always rises to the top and nobody really wants it. So I don't understand where it keeps coming from, because the carriers don't really like it, the patient groups don't like it. In Washington State, we've had bills on it for a couple years and it never flushed out. So I think that's one of the most concerning things, is not understanding what might be in line for a replacement they need, so I think walking it out a couple years is how they buy themselves time
Right.
and leaves us in limbo.
Yeah.
Right? Because from a state level waiting, you need to see what they're going to do to figure out how you react to
Right.
it. So the delay is probably good on a national level, but from a state perspective, it's difficult. In some ways, it'd be easier if they made a decision, but then walked out implementation for a couple of years, because we could spend time figuring out how to play in the new reality.
Yeah. Well, and insurance plans, again, without the knowledge of what it's going to look like, are going to leave the individual marketplace. All the analysis shows that. And so that's, I mean, I think a big concern for just the whole of the Affordable Care Act. It is one component of it, but it's a really important part of what makes the Affordable Care Act work. I think, I know that there's a couple of things, other things I wanted to say, but I think I'll just, we can turn it over if you want Erin to talk about the state stuff. You want to do that, Stephanie, and then.
Yeah. Well, and then just the other thing, because I can't remember if we hit on it well enough, just the understanding, and there's been, you can tell the insurance, I don't know if you noticed this today, but the insurance world is definitely moving in what they're trying to get their message across with, because Credle was in a couple of different articles today about saying that if you pull out the lifetime caps, if you pull out, all the stuff that we like, that the insurance market collapses, right? And so that's really important to understand, kind of like if you already have the cake, you have the cake made, and then you take out the flour after the cake is made, what happens? The cake's
We had a market collapse. I don't know if he was citing it, but I've been studying it for the last couple of weeks. In the late 90s, our individual
in the
marketplace
90s.
collapsed, and we're a model for the nation on what not to do.
Yeah.
And some of that, like, I'll pick up state a little bit, jump
And then I'm
in.
just going to define real quickly. So individual marketplace is going to be what we call the exchange,
Yeah.
which other people call like the marketplace, right? But we call it the exchange. And then the individual market is that if you're above that 400% above poverty level, you may go out on your own and go to Primero's website and try to look for a plan on your own. So it covers both of those. Is that correct?
Yeah, we actually have the same governing rules for both. So yeah, when I'm going to talk about Medicaid and then I'll talk about private, it's exchange and like where I buy mine. We have the same rules inside and outside the exchange. It helps with market stability. It was a good thing our state did that, but it also has the weird effect of now jeopardizing our whole marketplace if pieces of it are pulled. And I think as I get into this, I'm going to talk Medicaid and I'm going to talk individual market, because at a state level they're dramatically different in what can be done and where the state can mitigate. And on Medicaid, there's like 3 or 4 options. In the private marketplace, I call it like the feds could pull strings, and they could pull a couple things, and that's what we're alluding to, that if you pull the wrong strings and don't pull another string, it collapses. And so I've been reading up on like what happened in the 90s here, and there's a lot of articles, I can actually forward some to send around, of like it's our people, right? And I should give my background. I worked on the Affordable Care Act for the Cancer Society at the federal level and at the state level, and got to coordinate all the patient groups that worked on the exchange legislation, Medicaid expansion. A fantastic experience, and now still surreal experience to look at the whole act and figure out like if they do this, then we do this, because it's kind of like game theory or art of war. You just are trying to think, if they do this, where do we have options? So I think that the hardest thing is that everyone is concerned and interested, and actually the governor's office is texting me right now about another call on this, but like we don't know. I feel confident saying it's not going to look the same it is today. And I think that's discouraging for me, because even though we've worked on a lot of stuff, the collaborative, looking at some best practices that we got money for, we were about to work on a bill to do standardized plan design remember how we got a task force, the patient out-of-pocket cost task force started, and we were on it this summer. We worked with carriers, hospitals, everywhere. We had a great idea of getting a plan out there that would be good for our patients, just as an option. And like all of that kind of falls by the wayside, because it's hard to run a bill or try to address the areas we've still seen problems when we don't understand what the lay of the land's going to look like in our state. It almost is a wasted effort, which worries me, but it also is a big request from the patient community. So a lot of the patient groups are taking a step back, being like, maybe we need to focus our efforts and our ask on stabilizing Washington, no matter what happens at the federal level. And so that changed a lot, and I think that's one of the things we're going to see in Washington State for the next 2 years in the legislative session, is not as much happening in healthcare, as we're in a waiting game in many ways to figure out what they choose and actually can do at the federal level, and how we could help. I don't have the right word yet, like mitigate, soften the blow, get creative. Like the state does have a role as soon as the feds make a decision. And so that holding pattern's brutal, because I feel if they take action this year and wait for 2 years, there's a lot of what ifs, and then if they pass it 2 months before, or most likely 2 weeks before the timeline, it's harder for the state to grab it and amend. And so I know a lot of us are starting to brainstorm on that, but it's a different scenario to be waiting. They don't even have a proposal to look at to start to pivot against. But I do want to talk through some of the things we know and where we're already starting to talk to folks. There's a lot of interest and concern around Medicaid. We had an incredible Medicaid expansion. We hit our 2018 enrollment goals for expansion in 2014. So like not only do we have high enrollment, they came in right away. And if you remember the term welcome mat, which is one of our favorites from the state level, it was all the people that showed up thinking they were expansion eligible, but they were actually eligible for underlying Medicaid, old Medicaid, right? The one that the state pays 50%, the Fed pay 50%. So our enrollments just jumped. We have a lot of people covered, and we also did pretty well over the last couple of years on our exchange enrollment. So our state has a pretty big problem if we start to lose opportunities for patients on those. At the same time, a lot of the public health programs and the health safety net that we had out there is gone because we didn't need it. So you started defunding those efforts at Department of Health, at King County Public Health, at the public health departments. Hospitals started changing their charity care, right? They're not having to deal with people hitting the ER with no insurance. They were more moving to people that had high deductibles or more community benefit. There actually started to be a system change right now that leaves me concerned about the safety net for folks that maybe do slip through with whatever happens. That stuff we can start working on. If we have 2 years, we can start brainstorming that. Like we can create a list. Like the buying of time can give us some ways, because we cannot fund all the people that are on Medicaid expansion. Like they won't give me the numbers right now, Healthcare Authority, but I did some rough, really bad Google math, and I got a confirmation I wasn't horribly wrong I got a nod from someone on Friday, so I feel good throwing this out there. This is like a total estimate, but I think the expansion population and CHIP expansion for Washington State annually is $3 billion. So if I'm wrong and it's $2 billion, we still have a problem. And our state uniquely has a problem this year, which makes me hopeful this gets walked out. We have to fund the rest of that education mandate. Remember McCleary? How many times we hear McCleary? It's undecided, but the burden for this biennium is additional $2 to $6 billion. And this is the year we owe, because by the 2018 school year, per the court, the state had to do it. So the timing is really bad for us because the money isn't there to be flexible to backfill some of this stuff. That ends this year. So even if we have to deal with this next session or the next, it's a better lay of the land for the state to pick up some of the costs. And the ways to think about Medicaid when it hits the state, all of these are extremely theoretical because we have no clue what's going to happen. But block grants are beloved by Republicans in Congress. And a lot of states that have Republican leaders like block grants. So the difference of that is our state has, everybody's on Medicaid, it's a benefit if you qualify, all the plans look the same, and all the benefits look the same. Our state does not have cost shares or premium. That's a really big deal, and that's why it's so expensive for all the people we have on it. A block grant is a different approach, where it says like, you can have a lot of flexibility. So one thing to be thinking about as we move forward in the new world where I'm okay with a Medicaid block grant, which I can't believe I would ever say, but in the light of it ending, or a block grant, like great, the state can get creative. We are alive to fight another day on that. You draw down funds. We want as much flexibility as possible on who we cover and how. You draw down a chunk of money, a block, if you will, and the state manages who's on it and what benefits they receive. So why this isn't horrible, and these are the type of creative solutions we're going to have to spend a lot of brain energy on the next couple of years, is you can take that and broaden it to maybe grab those people that had subsidy in the exchange and recreate our basic health plan. I don't know if any of you remember that. Washington had it before the Affordable Care Act, and it was a set of benefits. It had a copay. It had a premium, which is probably a reality we don't love, but if it keeps people covered, as long as it allows for third party, this is a weird little thing that matters, as long as these types of plans allow for third party payment of premiums, we can get really creative. Like private entities can fundraise, the state can pay copays and premiums in some entities. There's this hiccup about needing to say that that's third party payments allowed. We had to do it on our exchange and in our high risk pool too. So our state has a precedent. So then this isn't amazing, right? But this isn't horrible. If we take the block grant, get creative, and maybe draw down some state dollars and start kind of a plan there. That is not, people live and there's coverage, right? It is not as good as it is today, but it's not the end all be all. And the big hiccup with that is how much flexibility the block grant is given. Actually more than the money. It's the flexibility to play around with it. Those are basically the only two scenarios. It's like just end the expansion or block grant that I've heard really have traction, because Medicaid doesn't have a ton of room to play. And I would say, as Washington State and someone that works with patients in Washington State, I would rather draw down a block grant than have the feds play around with coverage levels for the expansion population or coverage eligibility. I'd rather we determine that than a federal approach of limiting the benefits or limiting the people. So Medicaid, I think, will have one of the longer walkouts. That was 2 years in their thing. It could go to 2 to 3 to buy themselves time on how to do this. That is a little bit simpler, if you will. It's more damaging for a lot of patient groups because that's where so many of our folks are covered, and it will inevitably mean a change in what's covered or who's covered. But the switching over to like the exchange or private marketplace, that's the area that has a ton of regulations sitting on it that matter a lot to our folks that do. Anyone that has a chronic illness or a severe illness that purchases in a private marketplace, and a lot of it are the big top lines we talked about are important. The biggest one is if they pull that tax penalty for the mandate, that's where the system collapses. And I think you all know this, but I'm just going to talk through really quick how that happens. If you don't require people to buy insurance and give them a tax penalty if they don't, then a lot of people just don't buy insurance. And they get pregnant, they show up and buy insurance. They fall or they have an accident skiing, they buy insurance and go to the doctor. Or they get cancer or are diagnosed with hemophilia and they go buy insurance. So you very quickly blow up the risk pool. Like you can't, an actuary can't even price insurance in that dynamic if you're having people present when ill and get off when better. Like there are stories in the stuff from 1994 about, oh, these women were trying to be nice, but sending in a note to Primera like, thank you, I'll see you next time I get pregnant. Like, you can't do that. You can't just show up for the baby hit of $10,000 and pay. I think they cited one woman that had $15,000 in costs that had paid $1,000 in premiums. And this is 1998 or something. That is what we're all the most worried about. But I will say, states regulate private insurance plans a great deal. It's where the authority lies for the most part in every state. It's not the feds. The feds can take these big actions like the Affordable Care Act, and they can take actions like you can't not give people insurance because they're pre-existing condition. They can do big actions. But if they pull some of this, the states aren't preempted. So like our state could do a penalty, a mandate penalty. Our state could do a penalty if you show up to buy insurance ill or injured. Right? Like there's a tax when you show up in essence because you didn't carry insurance, which I, again, 2 weeks ago would have said was horrifying, but now I'm like, $1,000 penalty. Like if I have cancer, that's better than no insurance, right? I mean, the world of where this goes is so crazy, but those are all state level things we can play with. I think our state, because of that failure in our individual market, our insurance commissioner is very nervous about how the strings are pulled at the federal level, how the timelines look, and how we could mitigate on the state level. And I've already met with a couple of folks that work for some of the insurance carriers. I mean, they're super creative. This marketplace has been pretty good for them. They don't want it to go away. I think they're about to hit the federal level. The hospitals are going to hit hard at the federal level. That's a great messenger with Congress about the effects hospitals have had. And at the state level, I do believe the insurance companies in our state will work collaboratively with us to keep the marketplace open as much as they can. Some of it may be folks like us asking the insurance commissioner next spring, like take their plans, take them in, start reviewing them. But like we want them all to file, but they may need an out. If by the fall when it's about to go to sale, if they have no clue or the marketplace has dramatically changed, is there a process for them pulling out so that they'll come in the hopes there's a replace? Like that's stuff we can do at the state level, and that patient groups can work with the insurance carriers and the insurance commissioner on how are we going to do this together. I mean, I think we've collaborated with them on many rounds. Like when we were working the exchange bill, we were working with the insurance carriers and the hospitals and the doctors and everybody together. I anticipate a very similar approach moving forward because everyone has a vested interest. So on the private market stuff, it could be a lot of work and we could have a really important voice. This insurance commissioner is guided and in it for patients. Like that is what he comes from, that is what he cares about. I know that he's having a really hard time thinking about how it's almost easier, not better, but it would be easier to repeal the totality of the act and revert back and move forward. The way they're likely to do it on the individual marketplace and the private stuff will be hard. And what it's meant for us very quickly from a lot of groups is like pulling back on things we were going to work on, the advancements we were going to make, the tweaks to the system. I'm just kind of laughing at how upset we've been about the out-of-pocket costs and that some people are paying $6,000 a year, and now I'm like, wow, that was a nice reality to have for the last 2 years to complain about that, because that was a lot better than it was before. And I guess the good news I'll say is that the popular parts of this act are well known by a lot of the public. And I do think there will be extreme measures taken to keep the guaranteed benefit, not allowing pre-existing condition exclusions, but that has to go with a penalty of some sort. It is how that marketplace works. So the state could do that potentially. There's these things down the road that we could work on. I think the hardest part for me is that we have to wait to see what they do. Like, we can brainstorm all we want. It's already been 2 weeks, and we'll have more time to do it. And the good thing is we'll have a menu and we'll have a list. Like, a lot of people are around at the federal and the state level that worked this act and as it was enacted. And therefore, you can see the blueprint of when you peel this is the problem. Like, we have skill sets at both levels on this, because rarely is a large act overturned within 4 years. Usually staff's gone by the time you're peeling it apart because everyone's transitioned. And we'll have a menu for our state. I think the hard part's the uncertainty. And I know I'm going to struggle with it. I think you guys are going to. I think it's going to be horrifying if they take an action to repeal that looks to destabilize both Medicaid and the private marketplace with a 2-year walkout. Even though I'd rather have a 2-year walkout because we have time to work on it, that is very scary, right? We don't know what they're thinking. Something's going to pass that's now law that has a date that says this ends. And there is no way we can tell patients not to be nervous. So I think managing nervousness and channeling it is going to be on Stephanie and I and folks like me of like, here are the options, let's be thinking. I think at the end of the day, the odds of them shutting down Medicaid expansion are so slim. It doesn't pan out in many ways, political, financial, for carriers, for hospitals. Like, it would be very difficult to abruptly end it. So what happens in between, I have no idea, but something. And then the private marketplace, I think that's the one that's way more risky because it's very complicated, and they can push a lot of that down to the states. And so, again, for us, really positive note, I'm not even spinning on this one, is that our insurance commissioner works well with patient groups. We have standing meetings with him. We have weekly lunches with him. He has weekly lunches with the insurance carriers too. Like, he's in the weeds on this. And so our state, if a lot of it's pushed down to us, I feel like we'll do it better. It may be painful. Like, when I was thinking about that penalty that somebody gets if you weren't carrying insurance and you get knocked with $1,000, like, that's brutal. And I would never support that under most circumstances. But if it makes our marketplace not collapse, like, you know, these are the things we have to be thinking about of how do we educate. First of all, people, we really need to help them keep insurance. And so some of what we have to look at with Kreidler is like, how do we hold some form of the essential health benefits if it pulls? We were working actively about plans that did not have prescription drug benefits right before the Affordable Care Act. He had to issue a rule saying you had to offer prescription drug coverage as part of your plan. So he's an advocate anyways, but how do we push for like making sure these aren't horrible plans but that people can afford them? That can be state level. That actually can be state level. If they repeal some of the laws, because right now there's weird language around a new mandate, like in the Affordable Care Act it says if we pass a new mandate, like saying you have to cover prescription drug benefits, the state has to pay for it. So like we're gonna have to watch for when people like me brainstorm crazy ideas, then I go find someone that's smart that like studies insurance law at groups we have here, then call out we need this changed, and we might need to be pushing those up to the feds, like, hey, this is horrible. We would never want any of this to be changing, but if it is, this little thing needs to be pulled so that the states don't have to pay for it. So it drops onto the insurance plan and it's the amount is spread. Like, none of it's going to be like sexy, as you can tell. These are all like weird, wonky, tiny little things. We also have been working on our high-risk pool in our state for years. We, as patient groups and the carriers...
Why don't you explain what a high-risk pool
Yeah.
is? Because you'll hear it being talked about like, oh, if you have a pre-existing condition, we're going to bring back the high-risk pool.
Yeah.
So maybe kind of explain what that
So if people were
is.
denied, and usually it was because of a pre-existing condition exclusion, although there were a couple other reasons, they would get referred over to the high-risk pool. In our state, it's called the Washington State Health Insurance High-Risk Pool or something. I can't remember.
Wish it.
WISHIP is what it's always called. And it's brutal. I mean, I've heard that it was $1,000 a month. I heard when the Affordable Care went into effect. I've heard some of them are $1,200 or $1,300 a month. When the Affordable Care Act started and we had the exchange open up and you had some subsidies and that, a feeling from a lot of patient groups is, okay, we want people being able to leave the high-risk pool and matriculate over when they could find an appropriate plan in the private marketplace for 2 reasons. The plans were cheaper. Even the most expensive plans with good coverage were cheaper than the high-risk pool. The second issue is the whole way insurance works, you need as many people as possible to spread the base and spread the risk. One of the big things the Affordable Care Act did that's hidden is a shared risk above in that whole exchange and individual market. We're all like part of one plan in terms of risk. And this is a really big deal because versus like me going when I buy, Regents would just assess my risk and I'd be rated on myself. And so there are times in life where we all cost different amounts of money, right? And women in their 30s cost a lot. Those plans were jacked up because you're pregnancy age, right? So there were weird pop-ups of like the rating. So this shared risk is one of the amazing things of the Affordable Care Act behind the scenes that I don't know, we want to hold that at the state level because when you got a big pool assessing risk, everyone's rates are a little bit lower. So that piece, those are the types of things we could get back at the state level. Some of us got really nervous with the high-risk pool closing. We were like, I'm not sure we're ready. I don't think all these people can transition over. A lot of them are not of legal status to qualify for the exchange, and they are able to purchase in the high-risk pool. There also is a large number of people with HIV/AIDS that get these Ryan White dollars, a third-party payer. So someone with HIV/AIDS buys in the high-risk pool, and let's say it's $1,300. There's actually a government program in private dollars that pay most of that premium to keep them insured. And it didn't seem like the marketplace was dealing with them. Like the plans we saw on the prescription drugs are so bad in our state if you're taking a lot of meds and if you're taking biologics, you're taking specialty drugs. You know, my plan, 50% cost share on specialty next year, which I thought we weren't going to prove anything with 50%. But we started to say, like, wait, you have to keep the high-risk pool open. This is clearly working, but you can close it to new enrollees. So we kept it open and said that people could stay in there. The third population that's huge in there, and I'm not going to be able to describe it well, but it's Medicare, Medicaid eligible around kidney failure. I'm forgetting the exact title. So I guess the good news is we kept it open, and now there's going to be an effort to not only keep it past the sunset date, which is December 2017, so next December, but also maybe to talk about opening it back up so that people could purchase in there just in case. And so that's another thing that's totally within the state's purview to do. It has an interesting issue with how it's funded. It's funded by an assessment on every health plan sold in Washington State. So if Medicaid does drop and the exchange subsidies go away and we have less plans sold, we may need to find a different way to fund the high-risk pool, but I feel that that's very manageable. That number is within the realm of what typically the state can do.
When they were looking at closing WISHIP, there was something like 72 people on it who had hemophilia. So it's always been, so we actually were, one of the ways that Erin and I started working together is that we directly advocated to keep the WISHIP open just because, you know, what if something happened? It's where those families that could afford it and they had a child who was going to college that was no longer eligible on their plan went to buy insurance for their child there. That's kind of what that plan was, or an individual male who had a job that could afford that.
It's great to see the list now of the, I don't know what to call it, I want to say the disease group, but it's not just disease because it used to be pregnancy. It is so interesting to see that list go to this. Like everybody else, it worked. They slowly found the right thing, whether it was Medicaid expansion for that like single guy if it worked, or the pregnant women were getting on to full, because pregnancy was really high. People were hopping on and off of WISHIP when they were pregnant. HIV/AIDS is still in their kidney, and then basically, not the correct, I don't know all the statuses, but they aren't allowed to buy in the exchange. All the other disease groups have fallen off. They're not even there.
Undocumented.
Yeah, the undocumented is. Yeah. There's also
Which
a legal
is also-
status problem
Yeah.
with the exchange too. I remember like a 5-year wait or something like that. I can't remember.
And we have
They were
community
buying.
members that are in Washington that are buying on the high-risk pool for that reason.
So we'll be working a bill this year to figure out how to reopen that as a backstop. I don't see a lot of pushback because we were already contemplating it, a really diverse group, and I'm not sure there's a drawback right now. No one has to buy in it, right? It's voluntary. If we can get it restarted. These things always take a while to start too. I cannot say that enough. The way insurance cycles work, the way the enrollment dates work and stuff. When we work a mandate, let's say we were working an old school insurance mandate like we used 2 years ago before the Affordable Care Act. It passed this year, and it passed like in May 2016. The implementation date would be in 2 years to allow for those turns of the insurance plans. So it's kind of good when I hear the congressional talk about 2 years, but also I'm not sure 2 years is actually enough when you look at where the 2 years sit. Right. When something takes action, when they put the date, and one thing to not be discounted, it's not political but a reality, is that the 2018 midterms would fall in and around the 2-year. And I swear, if I was them, I hate even being thinking about how I would undo the Affordable Care Act is like such a weird brain to get into. But, you would not present your replace until after the midterms.
Right.
So I would walk my timeline out to end of 2018, because that's a plan year end. So, everyone stays on for 2017, which everyone's signing up right now. You do one more year, and then you roll out your replace after the midterms in the hopes that they don't lose a lot of seats. The party in control is going to want to stay in control. Midterms are a hard election year. So you wouldn't put something out to be torn apart right prior. So that's what makes me nervous from a state perspective is, let's say they do it the week or two after. We're at this time of year, right before Thanksgiving, and we go into session January 10th or whatever that year. So the brainstorming and all the lists that everyone will make over the next years, it's hard with legislators a little bit right now, and I'm having to peel back and take the holidays, because I got to, we just did this, right? We just did this enabling legislation at the state level 3 or 4, maybe 5 years ago. It was right before I left ACS. So I'm entering my 5th year, 4 years ago. So it's too recent for too many of us that can see the path, and a lot of legislators are new. A lot of them want to believe it won't be that bad, and I agree. I don't think everyone's going to lose insurance on one day. I agree with that, but that I'm trying to give time and space and then start some discussions about making sure we're starting to work now on some ideas so that we can pivot really quick, because I think we're going to have a weird 2 years of waiting, which is hard for lawmakers and for advocates.
Yeah.
I would say I'd be happy to live in Washington State. I'm happy to live in Washington State. We can't fund everything that might potentially be cut, but it doesn't mean we can't mitigate. And the state has been a leader in providing innovative ways, like our basic health plan, for folks that struggle to pay. And I still think, and our state may have a change. We have a midterm, if you will, next fall. We have an off-year election because Senator Hill died a couple weeks ago, who was a huge advocate of ours, died from his second bout with lung cancer. And his seat will, because of when he passed in the middle of his term, someone is going to fill the role for the next 6 months. And maybe Dino Rossi, you know that name. Dino may step up and be what's called a placeholder. So he will step up, which is actually pretty amazing. I'm not sure I would. This session is going to be rough and long. Yes. And what he's offering to do is just work there for 10 months and not run for the seat. And he wrote the budget when he was there. So, I mean, in some ways, he could be additive and helping with some of the education stuff.
And Andy Hill was so respected, don't you think that could be part of it? So Andy Hill, just, he, on the Senate side, was the reason why we got the Bleeding Disorder Collaborative.
Right.
So that's,
yeah,
a
his
big shout out to him.
death is just so sad on so many levels, but this, it would have been awesome to have him there to think about how this happens and how the potential federal action could be mitigated at the state level. This was something he was passionate about because he had stage 4 cancer and was cured by a unique drug that costs a lot of money, right? He had this reality on it that was so nice at times, so I didn't have to keep saying to legislators, no, you can't afford this, right? And he was wealthy and worked at Microsoft. He's like, people can't afford this. This is a joke. This is not okay. That seat is in a very heavily Democratic area. He was such a unique person. It was such a good fit for that district, such a good fit for our state. He's really one of a kind. And that seat will be up next fall. So that's really interesting because the Senate's only up by 1 to that majority Republican caucus. So we could actually see our Senate switch control a year out, which affords new opportunities and as well as some negatives in a leadership change. That means chairs change, it means all of them change, but it could mean a Democratic-controlled Senate and a Democratic-controlled House and a Democratic-controlled governor's office for when the state would grab the ball from what the feds did. So that's an interesting dynamic, too, in our state. Typically, although I agree, I'm done prognosticating. I think I've just embarrassed myself at every client this summer being he can't win. And I was saying I don't want to say it, but through the primaries and stuff. So I don't know if convention holds, but typically it is challenging in an off year where not that many people vote to be from a party that's in total control, either party. So if the Democrats are in control of Congress and the White House and there's a seat up lower level, it often can be a balance and go the other direction in a competitive seat. So in this seat, it is in a district that Dem performance has to be 60%. It votes Democratic 60% of the time. So it really could be at play. And one thing, it'll be so much money thrown at that seat. But it could mean we would have another change before our state was dealing with this, which adds another layer of complication for our work. So for our efforts, I'd say the only thing that changed really quickly is Stephanie and I had to reassess our ledge agenda going into next session. There were two, like I mentioned, aggressive things we were going to go after that had a good shot of going that were additive to the current landscape that as of right now we're just rethinking and pulling back on. Because one wouldn't work if too much changes. The other, it probably is not the correct ask of the state right now. We probably have bigger asks. And so that's kind of what I've seen as our bigger pivot in the last couple weeks. But it's going to be a long, slow session, so we have time to firm up as we get closer, as well as like just a huge band of saving space for whatever we may need to react to in regards to this.
Yeah. Did you have anything to? Mm-mm. And so before we kind of talk about like what BDFW can do and kind of what it looks like moving forward, especially as we go into a ledge day, how we look at programs. Oh, I know. There's most of these folks in the room have employer insurance. So
Yeah.
any thoughts on impacts to employer insurance that they need to have their heads up for or looking at?
Well, I think that the big ones that God knows what will happen now, that we're coming up to have discussions about were the Cadillac tax and one other. And as you guys know, the Affordable Care Act was going to tax high health, really good quality, expensive health insurance plans. You were going to start withholding taxes on those plans because it's, a great benefit to those employees. And so they put that tax into a holding pattern to 2020, and if they repeal, then all of that goes away, so, there's nothing there. But if it goes back to if they do reconciliation, and there are things that they were looking to change so that it didn't impact folks who, have a moderate income but have good health insurance and then are going to get taxed higher, they were willing to change that provision of the law, and so we don't know what will happen to that. So that is one of the areas of private insurance that could be impacted. So if you have really good health care, whether or not you end up being taxed, it's a little hard to tell. I think there's one more that I had written down, and it's
EHBs.
Yeah.
Essential health benefits are on all plans. I think that out-of-pocket both ways is on those too. So there's two things of out-of-pocket that matter. There's, the caps where they say they can't put an annual or lifetime cap on what they'll pay out for you, and then the out-of-pocket cap you have. I believe both touch. I'm not 100% on that, but I think they were system-wide.
I think so too.
And then 26, that's,
The pre-existing conditions.
well, staying up to 26 on private is in there.
Yeah.
Pre-existing condition.
Lifetime.
You didn't have exclusions on group plans, at least Washington State, we may have already banned that. Yeah, all those caps, I think, are,
Yeah.
and the essential health benefit, I can't say enough how much that mattered in the state. We were seeing tons of plans with just gaping holes around certain benefit structures, and so having that minimum, it is what many would say drove up the cost. I'm not sure it's a one-for-one there. I mean, certainly it makes the insurance a little bit more expensive. I would also say it makes it insurance, so before we were seeing people paying a lot of money and then like not having coverage for something. So that's one of the things at the state level will be an interesting discussion.
Yeah.
And I think anything new and innovative that was on the horizon doesn't move forward because we're all going to be dealing with how do we deal with the changes that are coming. I was listening to a public radio discussion from a European NGO basically talking about global health leadership, that the United States has been a leader in global health, and what impacts does dealing with the changes to the Affordable Care Act have on that, and so that the world is looking to us as leaders on health. How did we step in and help out on Zika, for instance, some of those kind of things. That could be hugely impacted by all of the discussions that are taking place to the repeal and replace reform of the Affordable Care Act.
You just reminded me of something else going on in our state. I don't know if you guys have heard about this, but our state has been applying for a waiver through Medicaid with the federal government. We're like one of 3. I know New York and Oregon have done it. It's called like an innovation waiver, global waiver.
1332 waivers.
It's huge, so it's $2 billion. And it's to do innovation. It's to like try different things. And the buckets our state applied to were around supportive housing, some intervention and case management work around, they call it like the boomer wave that's coming. So like not having everyone end up in nursing homes, and it's got some cool strategies. Those two equal about 600 million. 1.2 million was to go out to these groups or to do community-based work and working on preventative measures and mitigating some of the things that drive healthcare costs to these accountable communities of health. There are 9 of them that have been created across the state. So the funny thing about this is it moved really, really quick last summer. I mean, like really quick. We were in summer till July, or in session till July, and I remember seeing an email about the application for the waiver, like in middle of July, and it was going to be turned in at the end of August. So that's really unprecedented for a huge waiver. And even then we heard they're trying to grab it while Obama's still in office. Okay, so we turn it in. It's so vague. I mean, I still barely understand all of the structures, but at least now we understand it. We just had to, they were like, we have to move forward. So you threw in ideas, whatever. And we just got approved about a month ago, 6 weeks ago. And it was walked back a little. Our ask was $3 billion, but it was $2 billion, and the state says that's great. We were positioning to 3 and we wanted 2, and you know, they're all happy. So then the election happens, and a lot of us are like, wait, are we still gonna take $2 billion from Trump's administration to do innovation? Like, this is different than what anyone thought when we started it, and we're moving forward. And I had 2 concerns, and they've kind of been addressed. One was all of it was predicated upon the lay of the land now, all the expansion population, all the people buying in the exchange. And so if any of that were to shift just a tiny bit, can we still assume we can meet what we said we could? Because we had to give these projections, we have to save money, we have to show saving money, we have to get reauthorized every year for the money. It's not a lump sum, it's an annual check-in. And then I said, do we want to, this is just Aaron, this is no client or anything, but do we want to open up our books on an annual basis to the federal government and have this dialogue? Like, what does that look like? What could it mean? Like, we do some aggressive and cool things regarding patient care and certain lines of services around reproductive health, about healthcare for folks like LGBTQ. Like, there's stuff our state does that's pretty cool that is unique to Washington State or some other area. So, I'm like, wait, it's been 2 weeks. Are we sure? Like, I feel like I'm still adjusting to, like, what could be the lay of the land with Affordable Care Act. And basically the answer I've gotten is they really want it signed by the end of the year because they think it's going to be much harder to be signed even in January, right? Even though he doesn't take office till January 20th. And then I believe there are outs on both sides, can have outs at some point, whether it's initially, which I have not gotten an answer on, or on that annual check. There are ways for us to revisit if it's the right decision, but it's harder to get it signed after. And that $1.2 billion I talked about was going to do some cool stuff in communities that we may like. It was stuff around, like, what are the things that happen around people besides healthcare that help them have productive lives? And the supportive housing piece was actually huge. It was going to put like someone in some of the transitional housing or shelters to interface regarding their healthcare and other needs. That's needed. That's good stuff. So I trust people way higher than me will take that under advisement and decide on this. But that's a huge thing coming to our state and a very prominent position nationally because everyone watches these waivers. So it's been funny that we got approval and then like 4 weeks later the election went this way.
Yeah, there's a lot of states that we're looking to that innovation waiver to really start to turn the Affordable Care Act so that it really fit for their state because it was really designed. And so I've been listening to health committee chairs in different states talking about how excited they were for this upcoming session to really start talking about these waivers and how they can use these waivers and how the things that people in their state don't like about the Affordable Care Act, they'll be able to address at the state level. And so that, to me, also was a little disappointing because now, that laboratory of state policy where we can really learn from one another about Washington and what it does really well and why I want to bring it to my state of Minnesota or vice versa, that opportunity to do that and continue to serve high-risk populations and the other needs maybe of our elderly and others. We just won't have time to do that right now because we're focusing on undoing a law that took decades to create.
We're still going to do it, I think, so you can still look to our
I think we're doing it in Minnesota, too, because it was actually the Senate Health Committee chair that I had a conversation with about some of this. So, yeah. So.
Well, before we do the BDFW stuff, do we want to ask questions? I know that was a lot of information.
That was a lot of information.
And so
I know.
much unknown, and so much talking for so little known.
I know.
So much
It's-
unknown.
And Steph, I just want to acknowledge we lost the stream for a little bit in the middle of
Okay.
that, so let me know I can unmute the folks on the line if they have questions.
Okay,
when we're
I don't know,
ready.
maybe they'll type in if they have questions, or if
I
you
th-
guys
I
have questions.
I think we lost the type, so I'll go ahead and unmute them and
Oh,
then
yeah,
we can
sure.
see. All right, so folks, if you're calling in on the phone, you're live. You can be heard in the room now. So if you have questions or we can fill in anything you missed, feel free to chime in.
So does anyone have kind of any questions about all of that? And there's no such thing as like, dumb questions. I know they're both, that's a lot of info. So, yeah.
Well, I just have a,
This is Rebecca, and I really, really appreciate you doing this. It's just a lot of really good information. Like you all already said, you know, I think we just don't know 100% what's coming. And I would love if we could have sessions maybe in a month or so, kind of see whether we know anything new, what do we need to do, and how do we join to make this better.
Yeah, absolutely. And luckily, both ladies next to me are saying that's a good idea. And since we need them for their expertise, and maybe that's some phone calls and stuff we can make. But I think, as always, the BDFW is dedicated to providing as much information as possible and advocacy as we can. So we'll definitely figure out how we can best do that.
Hi, this is Mike. Thanks for the overview. It's very enlightening. I think the biggest mistake we could make would be to underestimate the pace of change. We know that in the President-elect's 100-day agenda that repeal and replace is there. And to hope that we're going to have 2 years to figure out what to do, I think would be silly on our part. And we have to start planning what's going to happen if the entire system is dismantled. There has been 510 days of people saying, this can't happen, this can't happen. And if we haven't learned our lesson by now, that many things can happen that we don't anticipate. I think living in the Northwest, we live in a bubble. And that bubble can make us immune to what is actually happening out in the rest of the country. So, although I would love to have that, the ability to have 2 years to think about this and to think about what's possibly going to happen, I don't think we're actually going to have that luxury, and that we've got to start thinking right now how we're going to be taking care of our patients when the ACA disappears at 500 days.
Yeah. Well, and I think when we talk internally about programming for next year, is that I agree with you that it's better to be kind of going plan for the worst and hope for the best. But so we're going to see a shift for like specifically our folks that we know are vulnerable. We know who they are because we help them sign up for Medicaid. We help them sign up for the exchange. Going and starting to talk to them and say, all right, hopefully you have longer than a year, but let's plan for a year. So you need to go apply at Starbucks. You need to go apply at Costco. So I think we can keep working on that together. To one, between the providers and the BDFW to make sure we're accessing all those vulnerable folks to get them the support services. Because I think that's what we can do as the BDFW while we let everybody else kind of figure out what their next steps are.
And I think it may have cut out when I got into that, so I'll just quickly reiterate that, like, we're already planning and groups are working on it. The 2-year problem, structurally from a policy perspective, we may hit is we may have a brainstorm list and all these ideas on what to do, but until we know what their replace is, the state cannot take action to go up against that. But the lists are already starting, so I don't want people to think because there's 2 years the work isn't starting. It's like, once we see what they do, we present our list and try to match it up both on Medicaid and the individual market. So not that the work isn't being done, but the bills really can't be passed until you know what you're responding to.
Right.
actually, is the replace and repeal in Trump's 100-day plan?
Just the repeal.
Just repeal.
And you can repeal without a replacement.
Yeah,
Yeah.
absolutely.
Except for since his 100-day plan, he put out his day 1, day 10 plans. It's not on there. And he
Yeah.
started to talk about the stuff he wants to keep and amending. He actually mentioned the word, maybe we have to amend some things yesterday. So I agree with Dr. Brecht. I think that we need to make sure that we are ready as an advocacy organizations, to mobilize our members to do what is necessary to protect access to care. And I think that that's part of what the next steps are is what can an advocacy organization do, what are the things that we need to know. You need to know who your newly elected officials are, what committees they sit on, all of those kind of things. And that's some of the activity that can take place now so that by the time they start on January 22nd or 3rd or whatever day is the first day of Congress, you've already reached out to each of your congressional, members of your congressional delegation. You've reached out to every member of your family across the United States who has because here in Washington, again, as a blue state, you may have a lot more Democrats on those committees, and so you're looking to your relatives who may live in one of those states that has a lot more Republicans, and so they're also sharing your message with their elected officials so that they understand when they're making their decisions how they're impacting people's lives.
He's squishy it's bouncing all around, and so is the congressional delegation. So, I know it's not helpful in that we have stuff we're going to work on, and taking breaks from the media is not a bad idea, especially on this topic. It's all over the place. I think in the last 2 weeks, the way it's landed that makes me feel better is a acknowledgement this is complicated, and some key congressional Republicans saying like this is complicated. Wait, you can't just do this, and we'll build up the stories and the noise. I don't know how much to follow it. It's driving me a little batty. Like every day it's different, and I'm not sure looking at all of it's helping me. Like we can see the trap lines of where they're going to go. There is a path in the Reconciliation Act from the spring. There is what we know about insurance. Like we know enough about where it's going to go that I'm not sure like the media coverage matters. So
And who's his health and
he
human
hasn't
services?
picked it, but he
Yeah.
had somebody. No,
Yeah.
there was a rumor about somebody. I think I need to take a break from those too until they're appointed. Because there's so much spinning, Like I got excited when Mitt Romney was speaking with them because if Romney was HHS, he did the
Right, he did
Massachusetts
Massachusetts
model that the ACA is actually built off of.
Sort of kind of walk back from them.
Yeah, but I think he understands the marketplace a little bit better. Again, I think a lot of legislators understand Medicaid. Medicaid is black and white in some ways. The insurance lay of the land is super complicated, and that's where Romney did the most stuff that was interesting. But I guess it's Secretary of State, which is also, yeah, please take that. Like, that would be amazing. Like, just, that would be a good person out of all the choices. So who he puts as HHS is very telling, because there's another layer a lot of us are worried about that's regulatory rules.
Right.
That tweaked little things. Like one I followed was about you go in for a colonoscopy. It's a preventative screen, so it's covered 100%. If they take out a polyp during the colonoscopy, which then prevents cancer, you get a diagnostic charge, and you're paying your deductible. That was fixed through regulation, and that's only one I know about. So there are so many. So whoever HHS is a big deal.
Right.
I bet it's coming soon. I mean, those top cabinets, which will give us, but give yourselves a break. Like, honestly on that, like, I'm not sure it's helpful right now. And the media is so spun up from such an incredible election cycle that they're still having a hard time calming down. And so they're spinning on a lot of stuff.
They're
and
running on adrenaline.
yeah, for us, we know the work. We know where we have to focus. And it's better for us to be focusing on, like, on brainstorming ideas or whatever. You guys can focus on grabbing some key stories and targeting certain congressional members. Like, that's meaningful. Plus, anything you guys do of collecting stories and getting people prepped to speak about, I got expansion, here's what happened, Medicaid under expansion, and you talk congressional delegation, it all builds our force for the state level. So it's all going to build. We're going to hit at multiple levels, just like we did on the Affordable Care Act. So that's our work. I don't know, I just keep my head down and try to focus on what we can do. Else, I feel I can get pulled up into a lot of stuff that isn't helpful. Too much what if. I'm okay with, like, it's going to change. I don't know how. I'm not sure I want us diving down too much every day of what it could look like, because the bottom line is they have no idea. They don't have a replace. So they're going to spend a lot of time figuring out how they're going to do this and what they're going to replace it with, and that is not for you guys to worry about. Like you have us, all of us, you have so many people working at the federal level and the state level, and like just telling the story of why the Affordable Care Act matters to you or a family member or whatever, that's your biggest job. It's like with your friends and everything, but it's when Stephanie asks for stories and getting trained on your story so we get it down to a minute, right? The stuff that matters, like that's huge. And only you guys can do that. Like you're the messenger on that piece. And that's what will mitigate a lot of the bad ideas that are thrown out there, is the real people. It is very nice to theoretically think about ending Medicaid expansion in a room. But the minute patient stories come up and the reality of the numbers come up, that's where you see it hopefully soften, right? We can mitigate this. I do believe that at federal level and state. I just think that maybe the piece you can deal with and sink in, that I've been letting sink in, is it's not going to look like it does today. And so that's kind of sad.
Well, and I think when I hear, because I've watched her evolution, talk like the day after, right, that mitigate doesn't mean it's not happening, right? Mitigate means it may not be as bad as it could be.
Like when I'm having to say I see an opportunity in a Medicaid block grant, like I never thought I'd say that. There's a new reality of opportunity. It doesn't mean it's all like what we want, but at the same time, like we can, I had someone at a board meeting last week that literally was like, I'm not sure I don't want it all just to fall apart, and they can feel this, and I'm like, okay, so people are gonna die. I don't think, like, it's recent, like, give yourself a couple weeks and process this, but, like, you can take that militant thing, or we can figure out how to help as many people as possible, maybe have some premiums for a while, and literally live to fight another day. Both with your health, for everyone that buys on this, and for a new, this stuff cycles around. We just have to make it be as least horrible as possible.
Yeah. And I just want to say for a person who travels across the United States and works with a lot of different of the chapters and associations, that you guys here in Washington have great leadership. You all have done an amazing job at the Capitol, the way you show up, getting to know your elected officials, sharing your stories, just keep at it. I think that that's one of the critical things that you can do, and really defining what the Affordable Care Act has done for this community, so you can articulate it. Even if you have private insurance, if you have a story that you can share that's of a community member that's okay with you sharing their story, those are really important as well. And it's a year-round process, so you need to know your legislator, and you need to know him or her year-round, and be willing to reach out and check in with them and remind them that you're a constituent and they work for you. I mean, you don't have to say it that way, but you know what I mean.
And we'll help. I mean, one thing that Nicolette shared with me, which I was like, oh, isn't that so awesome, is that she doesn't know how to articulate what life was like before ACA.
That is awesome.
And so how do you advocate for it? So that's where we'll come in, right? We'll get you the talking points. We'll figure out what the best message is, how to get that across. That's, we'll train you guys again. We trained you how to say, let's figure out how to do it better. So now we'll figure out how to say, let's save as much as we can. This is why I'm worth it. This is why my child is worth it. And then what we leave behind too is, so-and-so elected. If you need a story, if you need me to show up for that, or some of them like media more than others when 7 calls, if you need me, I will be there, right? And we've had that over the years. That's why at certain times BDFW had so much media coverage, was because they knew that they could call, and we would have the lifetime story cast. I mean, we'll plug in and do all those things again.
We're more coordinated. Another positive. Yeah. We don't really have a name, but like a lot of patient groups that come from different disease states, and we have no name. Chronic disease, but they're not all chronic disease. But
do you know why we have no name? It's because we get stuff done.
Yeah, we don't need a name.
Who cares what the name is with the colored logo?
Yeah, it's a phone call and an email list. Extremely coordinated. We actually were not this coordinated when the act passed at the state level, so that is a huge difference. Like, we had a call the morning after the election to talk about our standardized plan design bill, which quickly reverted into, my God, we're going to have to work on the Affordable Care Act. But ready, willing, and able. Everyone flipped. Everyone got it. It was the shortest call I think I've been on. It was 3 minutes, saying we'd talk in a month. But you could see stuff falling off their agendas, too, to save bandwidth and resources and be extremely coordinated. So I think having a lot of the patient group coordinated, and I'm honestly going to try to have us work with the carriers and the hospitals and everybody that cares about this staying. I just, a couple of years ago when the funding for the exchange was under attack, I started a coalition of lobbyists that were the insurance carriers, patient groups, hospitals, doctors. It's a hodgepodge of people that rarely work together, and we saved the premium tax that funded the exchange. And I've already had a couple calls to restart that, so why not? Like, it means we all sit in a room each week and brainstorm, and I think if you have patient groups and insurance companies thinking about how to mitigate some of this, those are the right people to figure it out. It's not just going to be insurance companies. It's not just going to be us. So a lot has advanced in our state that I think is going to make this a collaborative. And like I said, the governor's office is all over it. I mean, I think it must be really scary to be a governor in a Medicaid expansion state right now because they're kind of freaking out. But we have an engaged governor that cares. So our state, when I look at a lot of them, is likely poised to mitigate as much as possible. Except we have no money. I mean, just like that piece.
There's that one.
If we were
piece
from an
that
oil
you-
state, we would be
Even if you were
better.
in Minnesota,
North
you would
Dakota's
be
money
better
or
off,
something,
yeah.
or Alaska. But once we clear McCleary, and these are the types of
We'll
efforts
just raise
that,
taxes again.
yeah, these are the types of efforts you do see on the ballot often with the funding source to fund it. And so that's not out of the realm.
Yeah, which is
Not-
likely to pass
that
here
would
because
pass.
it is a heavy blue state, right?
So many opportunities.
Just a lot of work. Any more questions on this, and then I'll talk programming with what our thoughts are for this.
Good question.
Oh, sorry.
Now, I was just wondering, in general, what has been the response of the insurance companies to the ACA? Is that too
They-
vague a question?
They like it.
They
They
do?
like
Okay.
it because it has some of the reforms, but it has L-Speak ones in our state. That's what I talked about. It has the mandate that people have to buy. So,
So it's been good for them in terms of enrollment.
they're just starting in our state to figure out how to do it right with their pricing and their like actuarial assessment and having everyone enter. We also had a big uptake in our exchange plans. Like there were a lot of people without insurance, right? And they came in and they used resources. And so I think like it's just balancing out. They also again had a lot of this back end risk assessment and risk sharing that a couple of them expired, which could be brought back in at the state level, but they liked that. They like sharing a risk on there's this back end adjustment that like if for some reason tons of sick people, tons of our people went on
Or
Primera.
one person with hemophilia
Yeah, blows
goes on
up.
a plan and costs $5 million that year. What it is that the other plans had to
All
help
of the
pay for
plans
it.
help.
Like on the back end.
So therefore, you guys weren't so scary, right? Which is great. That's what we want. But that's for you guys in this room. You know that is, even $1 million, $2 million. That's not.
They didn't have those before, so they were very risk adverse. That's where you had adverse selection, these terms of they find ways to not. Rescission's one of my favorites that used to happen, where you'd get dropped because you forgot to say you had acne at 13, and now you have cancer, and they're like, you didn't declare the acne. So
we're
and
taking
the
away
poster
your
child of
plan.
that at the national level, she was amazing. Some of those things we can keep at the state level, and the carriers aren't opposed to. I think the carriers are very afraid right now is the better answer or better question I'm having you ask me. How are they right now? They're very nervous and they're highly motivated, and they didn't see this coming. And so they're same with the hospitals. Those two entities matter at Congress a lot because they are good messengers on the totality of the market and what could happen, but also they're great messengers with conservatives. And hospitals in rural areas are also often the biggest jobs, like the job provider. And so when they all are rallying there, it's important. And the carriers will be mostly talking about the out of Medicaid body.
And I
They
think
want to
that,
mitigate it as much as possible.
Dr. Reck feels about that one.
So, and I think that, with the insurance plans, just a little bit, I think that what Erin said earlier about, we were starting to see systems change. They were, on the receiving end of that those first few years of being on the marketplace, they incurred losses, they didn't quite have down how to make it work. And now they've set their systems up to that they can work and they can make money on them, and now this is coming at them, so.
Well, there
really
was a big hullabaloo, 3 months before the election, where a whole bunch of insurance companies said we're pulling out.
I know.
Was it just not that many, and it was just a lot of media, or did
Our state had Primera pulled out of 12 counties. So there were some shifts. There were also some that came in. It was a lot of national posturing, but we did see, and Primera is a big player in Washington State, so that was concerning. Primera also got, and I'll disclose I work for Providence, I feel like I have to say that, but Primera and Providence also got in an epic battle for 4 or 5 months and ended the current contract and couldn't come to an agreement. And Primera ended up with some other hospitals. And so there is some validity to that. I feel like Primera just balanced out and figured out how to price right this year. Like they underpriced. I think many plans
Yeah, a
underpriced
lot of
people
plans
coming in
underpriced.
thinking they were the healthy young invincibles that hadn't been buying. But the problem is, if you haven't had insurance and you're 28 and you're healthy, you still have health issues usually. You still need tests for baselines. You still need, and I'm not sure they capture that well. And so now they condensed in, they came out of those 12 counties and they were moving forward kind of tight. And I think what a rebalance, and I swear United came in big a couple years ago and has expanded. Like we honestly have too many plans available in the exchange right now per
That's the issue.
social economics. They have these models of how many choices someone can handle. And by the way, it's true because I went on the exchange the other day and I got overwhelmed. And I'm just buying through regions again because I have 4 options. So we actually had so many plans offered in our state. The trick is in some counties you don't have competitive choices. But I feel like a lot, looking back, there was a lot of posturing around a couple topics by a lot of entities right before the election, and I don't know, maybe that's normal. It's just I've never been through a cycle this overblown, like this incredible, and this 24/7, and this. So I feel like everyone started popping up, like, yeah, I don't really like this, I'm gonna pull out, and I don't. It'll be interesting to see what shakes out, but they're all filed. I'm sure every state is similar to ours, but by the time they were saying that, they are either on the marketplace and filed in the state or not. So Primera was on, they just were reduced, and other ones, like what they maybe could be speaking to is their behavior pattern next April when they file for the next year.
So good. So for the BDFW today, we'll keep you guys informed, and everything right now that I'm sending out has a lot of asterisks on it. So, we have all of our programming set for the year, and normally at this point in time, we go through and say these are kind of our target messages, our target education moments. If this keeps unfolding as we anticipate it, there'll be that insurance update at every single educational event. And if that's what the whole entire meeting needs to be on, then that's what the whole entire meeting will be. And then we'll wait on the other topics. For family camp, we haven't had to talk about insurance. We'll put that back on it to kind of keep people educated. Our biggest shift will be for our IB leaders. So all of our kids' ages ranges from 15 to 26, and all those people that we did sign up beforehand, like I was telling Dr. Reck, is that we'll go back through and say, yes, status quo looks okay, but we highly recommend that, I will be happy when you're mad at me because it took 18 months or 2 years for this to unfold, but we encourage you today to figure out which of these 3 employers is one you would like to go get a job
Because they
at.
have really good insurance.
Because they have really good
That's
insurance.
insurance.
Right, and it takes 5 months to work at Starbucks before their insurance kicks in. It takes however many long months at Costco before your insurance kicks in. And you want to do it before everybody else behind you figures out the same thing.
Yeah.
So, it was really awesome to be able to let all these kids, pursue their film careers. But because I can see the child in my head. And he was working at Starbucks. We're going to have to tell this young man who I know is currently on Medicaid that you need to go back to Starbucks. Just because it's better, it's the safety net that they can count on is themselves, right? So now we'll go to this a kind of a different shift in model. And I think that will be hard for folks. And then, definitely, like I said before, working with the providers on, and we have such a strong relationship, and is who do you see coming through, and we'll figure out if there's a form or something that we need to start doing as they come in throughout the year, trying to figure out if they're vulnerable so that we can keep that database going so that we can help find them. And then working with, the drug companies on what are going to be their new approaches for plans to cover co-pays and premium assistance and all those different kinds of things. When it comes to our advocacy efforts, obviously I'm much more Washington state focused than I am federally focused. But I have had conversations with HFA on what they need. We're not going to send a ton of people to Washington, D.C. because most of our folks are our allies. So there's no point in me going and sitting and talking with my congresswoman because she's already my friend. And it cost me $2,000 to send me to go and do that with flights and airfare. But if I have anybody in Rikers District, we'll do this very strategically to use the BDFW resources to the best of our ability.
And you don't have to go to DC.
Yeah,
You
have
can meet them
somebody's
in their district offices too.
Town hall meetings coming up, calls. And we know how to do that. So it's just giving you guys the right talking points and going out there, and you know how to do it. It's no different than asking for money for the walk. For some of those, that do that. It's telling your story, and this is the vote that I need, and this is why.
We need the story inventory though. You can figure out how to do that, but you should be trying when you talk to people to capture it. Like there's specific stories that are gonna work here and some that aren't. Like the employer-based stuff is not as compelling. Like we need people that are on Medicaid expansion and buy in the individual market. Whether it's exchange or just like me where I buy from Regents. There not that your experience with employer-based doesn't have some risks, but it's like not the compellingest out of all the stories we can tell. Medicaid's gonna be the huge one, but I don't know if you have folks, but if people that get subsidies, I'm so nervous that's gonna be overlooked because of Medicaid.
Yeah, no, and we know who all those folks are because we signed them up. You know,
So we need to like start pulling their stories together.
Yeah.
And you do need to pay attention as we watch what it is that they're, that might go away, because that the lifetime cap, so for those who do have private insurance or through their employers, those lifetime cap stories, those historical stories, I think are important to continue to share, because even in these last few years, it's just such a lovely reality that people weren't threatened to lose their health care after 2 years because their 5-year-old maxed out at 5, right?
Right.
And then the state Medicaid is suggesting that they get the parents get divorced because it's the only way that they can cover the kid. I mean, these were true life stories that we heard before the Affordable Care Act. So I think it's important to remind the elected officials that it wasn't all that long ago that this was the reality for people in the bleeding disorders community.
Yeah. And we can get it down to, where, like, if I was doing that spiel, and I'm, Jessica or Nicolette, being like, my child is only 5, and my child cost $1 million a year, and what if I didn't have the lifetime caps? And that's why it's here in ACA. But as a mom, I'm even more concerned about the 21-year-old that I see at every event. Because you share your thing and then you pivot.
Grab a story.
Like, I'm still important and my kid's still important, and then you pivot to, but what's even worse? Is this kid right here? This is what he doesn't, if we don't have the insurance, this is what it is. And we can train you to do that, and we can write it out.
Because your stuff in employer base is gonna be saved or mitigated if we do the stuff in the individual market. But if we just focus on employer base, we won't mitigate the subsidies. Does that make sense? All the issues that you guys have in employer base also exist in that individual market, but the bigger problem for individual market is the subsidies.
Yeah. And
that concerns me because there's no option. Even if expansion stays, they can't, unless they start losing a job or do the spend down to qualify, quit their job to qualify.
Yeah.
They can't go there, and I believe, and again, some people would say the rates could drop if the essential health benefits fall off or something, but right now I'm trying to price out buying, and the cheapest I can get myself down to on a silver plan with no dental, no vision or anything is $387, because I'm not going to tip towards bronze because that's not insurance. So $387, the subsidy people can't pay. It's a non-reality. So that's why we can tell your guys' story through that lens too, but we don't want to miss saying the subsidy is huge.
Yeah, and we have those stories, and that's what's exciting about being a hemophilia advocate is that you always meet the story. So you often are called. That's why we testify so often, right? Because some groups will be like, I don't know any lifetime cap people, or I don't know any of this kind of. I'm like, oh, which one do you want me to call? Because they're all here on my phone. I just text them. And some of you have gotten those texts before. What was your out of pocket last year? And are you available on Tuesday? So that part I think is, if you want to have a fun with any of this, is that this is an opportunity to share your story, because you guys hit those extremes all the time. And I think it's hard. You guys benefited the most from healthcare reform as a disease group compared to a lot, and this may be the most painful for you guys as well. But it doesn't mean that you're not going to give your chance to get out there and to try to share your story.
I think it's so important with your friends and allies in this community too to be realistic. I'm not at all saying we don't say stuff's going to happen, because it's going to change. But at the same time, there's so much fear, and I understand it completely. I mean, I know the lay of land prior, and I could likely lose insurance too, and I'm not sick, so it's not as big of a deal. I get it. But as much as you can talk to people and be like, yeah, things are going to change, but try to have a message of we're going to try to mitigate, we're going to try to have it not be horrible. I'm so nervous about how some patients are feeling, and I don't know that they need to be there yet. And I'm not sure that going to that at this point of so extreme dire is going to help us get people to come testify and stuff. Talk about how there's opportunity here in Washington State. We're already planning for what the options at the state level would be. so that that federal drumbeat doesn't just freak them out and wear them down. And again, it's hard. I mean, it's constant all day on the news. So as much as you can do that, I think it's critical. This could also be a great way to get some of your friends and allies to come down to Olympia for our Advocacy Day. You know, a lot of what we'll be doing is telling stories, and it may be a way to get them to feel like they can do something and see. I mean, I believe the lay of the land and the dialogue in Olympia, even this session, will be more upbeat than the federal drumbeat. So maybe they would find it reassuring.
Yeah.
I don't know if that helps. Like, I don't know the line to walk. Like, I don't want you to say it's going to be fine. I'm not telling you to do that. But like, we have some power maybe that people need to hear to work on it here. So whatever happens at the federal level, we still have a space to impact this for our folks.
And we have Erin. The board makes an investment in her every year, and that's really fantastic.
So I can come here and spin this as a positive to you all. I'm spending a lot of time finding these openings and creating these conversations. Like, it's our space. It's why we're not going after collaborative refunding, and it's why we're not going after standard plan design from the whole patient community. It's to open up space to like be asking everybody to brainstorm and find ways to.
Which
So
is
if they're there, we'll find them.
Yeah, and I think as a community tempering, like we've had these awesome successes with advocacy, but we can't ask for money for research when we need, the ask is please figure out a way to pay for our folks on medication. Right, I mean like, remember, what's the cost of Medicaid for hemophilia per year? $72 million for 143 patients. That's a huge ask. That is a huge ask. You know, we had the CDC that was interested in working with us on a project. The federal government, when it's controlled by 3 red houses, that does not give a blue house a bunch of money for a fun project. You know, like, and how that funding's going to lay out and what that's
The
going to look
CDC
like.
cuts are going to be interesting because there's also a roadmap on that we've seen the last couple of years. There'll be some cuts in some departments like that too.
Yeah, and
That's okay. Like a lot of that is prevention and like it's not direct cuts, service cuts.
Yeah.
Is what I'd say.
but the fun BDFW advocacy efforts now are going to switch to a little bit different, and it's just important for, you know, there's board members in here and stuff like, oh, how come now we're not doing all this great stuff? Well, we are. It's just a little bit more nitty gritty.
What were those numbers again, the millions and the numbers?
What they have said is that it's $72 million for 143 patients.
They
Claim
said
costs.
being whom?
HCA, it's claim cost, right? Claims, it's payments out. So I think she's saying the healthcare authority has said that the 140 people with hemophilia on our state Medicaid costs $72 million in costs,
Per year.
claims.
So it's still some insurance.
It goes to the state.
To the
The
state,
state is the payer, yeah.
right,
Yeah. So that's just a big ask that we want them to keep funding.
Our community is very
Yes.
prevalent, or a big portion of costs within Medicaid, and they know that. That's why they want to do the collaborative. That's
Yes.
why.
Yeah.
Do you feel better or worse after listening to this?
Better.
Okay,
Great.
cool.
Yeah.
We got stuff to do.
Yeah, I don't want to walk the line of like scare tactics, but I'm just trying to get a gauge of what people want to hear. And really take some media breaks. I cannot say that enough on the left and the right and the nonpartisan. Just take some breaks. It is not helpful on this topic right now. Yeah, take a Hallmark holiday. Like enjoy the. Put it away. I put it away this weekend. It took a break. And it was
Hallmark station.
Yeah, that's
I
what
know,
we're
that's what I
saying.
said, Hallmark holiday movies, you know, sing some songs.
I'm just getting caught up on Game of
ABC
Thrones.
Family
That's
was
what
all-
I'm
I
doing.
know.
Oh, there's some good stuff.
And there's some good politics in there.
Okay.
Steph, are we good to
I think so,
end?
unless anyone on the room has questions.
If I can get quiet in the room 1 sec. Just before we sign off here, open it up to folks streaming online if there's any last questions. Going once, going twice. All right, we'll call that a wrap.
Awesome.
Thank you.
Thank you so much, and thank you to Erin and Kim to being with us. And